everybody. Today's webinar is on patient-centered communication, advocacy, and cultural humility. This is a part of an ongoing educational activity organized by the New York Mid-Atlantic Consortium for Genetics and Newborn Screening Services. We are pleased to have with us two exceptional speakers and advocates who are going to present on today's webinar. Before we begin, a few housekeeping items. Should you have any questions or comments for the speakers, please type in your questions and comments in the question box that you may see on your control panel. All attendees are in listen-only mode, so we really appreciate you typing in your questions and comments in this toolbox. At the end of the webinar, you'll be prompted to complete a brief evaluation survey. Kindly share your feedback. It really helps us in planning our future activities and help us to improve in offering our educational activities. Thank you once again all for joining. And on that note, I invite Adiomi Utuk to present on her experiences and thoughts on patient-centered communication, advocacy, and cultural humility. Adiomi is a young adult and a strong advocate for sickle cell disease and is associated with the Sickle Cell Association of New Jersey. Thanks, Adiomi, for joining us.
No problem. Good afternoon, everybody. I'm so excited to present to you all, share my feedback. A little bit about me. I actually live with a disease called sickle cell anemia. I am SS. And I come from a family that also has been going through the same experiences of having sickle cell and learning to deal with it. I am a huge advocate for the awareness and education of sickle cell in all communities. In 2009, I actually founded my own nonprofit called Converse for a Cure, where the mission was to raise awareness about sickle cell disease through art, fashion, and entertainment. I'll talk a little bit more about that later. But in 2010, I phased that out to begin a direct partnership with the Sickle Cell Association of New Jersey. And that exists still to this day, where Mary Lamar, and I know she's on the call, we work very closely in leadership roles to coordinate, host. I'm also a photographer and spokesperson for the organization. And I'm currently the co-chair of an exciting research opportunity funded by the PCORI Research Grant, which I'll get to later as well. So with that brief introduction, let's get started. As Kunal said, I am a huge advocate for sickle cell disease, and I just want to take you guys through the story of my sister and I. We both are living with sickle cell and have experienced different things that I think you guys will find interesting, helpful, and educational to take along in your journeys as you become professionals in the medical field. So can I go to the next slide now? So once upon a time, there were two girls born to Nigerian immigrant parents in 1980 and 1985. 2 of 4 have sickle cell disease, SS. So now you can hit, this is a picture of my family. You can see Edie and I, at our very young age, have sickle cell disease. My 2 other siblings, thankfully, don't have the disease. One, my brother is AA, and my younger sister has a trait. Although Edie and I were born with the same status in regards to sickle cell disease, our journeys have been very different. I was confirmed of having the disease at 8 months, and Edie was confirmed of having the disease at 11 months. Growing up, my mother always used to say that I was very sick, and she didn't think I would make it. I recall my first pain crisis at the age of 7, where due to extreme pain in my right arm, I didn't move it, which is a common, symptom of sickle cell pain. I kept it close for about 2 weeks, and that led to a deformity of my right arm. At the time, the doctor, my pediatrician, thought I had broken it. But you can't break something if you never moved it. I think I've deduced that due to the lack of oxygen and blood flow, it stunted the growth of that arm. However, growing up and as we got older, Edie and I, the table sort of shifted and Edie's health became more chronic. Next slide. So something happened in 1994 that changed our lives permanently. It was a Thursday when my father took Edie at the age of 14 to our local doctor's office because of a pain crisis. The doctor gave him an excuse note for her to go back to school on Monday and, stay home and rest and possibly take Tylenol. That Friday night, my mother came home from work and saw that she wasn't looking well. She thought Edie would die, basically. Just a side note about my mother, she's a nurse anesthetist. Later that night, she found Edie unresponsive with her eyes glazed over white. With that, they called the ambulance and took her to the local hospital. While in the ER, the attendees couldn't find a vein, which is regular for sickle cell patients. And thankfully, due to my mother's background and the oxygen that was given to Edie during the ambulance ride, they called my mother from the waiting room in the ER, and she was able to find a vein. This is important in our life story for my family because that sort of changed, like I said, the trajectory of Edie's life and our life as a whole. This provider that sort of misdiagnosed the symptoms that Edie was having definitely altered her life. And at that night, we realized that Edie was sick due to kidney failure. It was a complication due to the sickle cell. Though, it's been very scary and unfortunate path of sickness, we were able to be introduced to the sickle cell facility at the Children's Hospital of Philadelphia. And with that treatment and care at CHOP, we met a doctor named Dr. Frank Pong. You can go to the next tab, Kunal. Dr. Frank Pong and his team were, in my opinion, the best hematology team that we both were seen by. Now, despite the challenging times of Edie's health and my health, his team gave us hope when we had none. There was an instant connection between our parents, being that Dr. Frank Pong is from Ghana and we are from Nigeria. I can specifically remember that his team sat down carefully to explain to us what their study was all about. And this study was specifically for a medicine called hydroxyurea and many others that we were to take part of in future years. They were very specific about how this study would help us. They were extremely passionate about our health and our survival. They were never dismissive. The team became staples in our relationship and in our lives. And it even got to a point where Dr. Frank Pong gave my parents his personal phone number if anything was to happen. That meant a lot for us. Living with a chronic disease and sort of not knowing how to navigate it. When you have medical professionals who are able and willing to see you as human and be very open and receptive to your concerns is extremely helpful. So that's part of the key learnings that we got from this experience. When treating patients with genetic conditions, it's always valuable if, one, you find a common ground. Two, you listen and address their concerns in a big and small. Three, you create a safe environment where patients feel welcome, educated, and most importantly, empowered. We want to know what's going on, The fourth and almost final step is to set up a clear plan of action and set expectations of what we can expect, living with the disease, how to treat it, where to be seen if you can't get to your hematology clinic. All these things lead to better decision-making, involvement, and happiness. Next slide, Kuna. So, in the name of advocacy, when I think of advocacy, many things do come to mind. The voice of the patient, the organization speaking up for the rights of the community, awareness, funding, equality, so much more. All of those points must exist due to the current state of our healthcare. And in speaking to my mother, who is a huge advocate herself, she states she's not sure exactly who the advocates are, but in her mind, there does need to be an advocate if the public and healthcare system don't take care of the population at large and pay attention to our individual needs. Unfortunately, this sort of utopian idea doesn't exist today. So we do need to advocate for ourselves and rely on organizations like this SCDAA and SCANJ to do so. Unfortunately, also, if the issue doesn't directly affect you, if sickle cell doesn't directly affect you or your family, you tend to not really care or want to be educated about it, which we think is wrong. You don't want to take this one initiative and just raise money for that one initiative when you see others that are suffering as well. I know it's very utopian, as I mentioned, but this type of thinking, I think, is something that will help you guys, approach medical care in a different perspective. And I think this point deserves deep consideration. Next slide. So as mentioned, until we come together and look at all different diseases and all ways these things affect different populations, we'll have fragmented and extremely disparate levels of care, quality, and funding, and also support. We'll have to, of course, continue to be advocates for ourselves with the help of the community organizations like SCDAA, SCANJ. Note, SCDAA is the national organization with local and state chapters like SCANJ. So SCANJ is specific to the New Jersey population. And there are many state and local chapters who advocate for sickle cell disease. As part of the continued advocacy and awareness, there's programs like Get Connected, and I mentioned PCORI, which stands for Patient-Centered Outcomes Research Institute. SCANJ is a part of a groundbreaking effort spearheaded by this organization to have patients' voices heard by the scientific research community. So our project is entitled We'll Take the Village, where we engage the community to better health. And it's made possible by PCORI. So this is exciting for me because patients are involved with developing the research questions. And it comes directly from our mouths to the researchers with which we've engaged and taken to, funneled into research, basically. Next slide.
All right. Adiomi, I was wondering if you would want to cast the audience poll questions at this point.
Sure. Let's do the first one.
Okay. So the question is, patient-centered communication is applicable to doctors only. Please choose the best option from the choices you have. A few more seconds. So I think that's an anticipated and expected answer. So yeah. All right. So let's do this second poll. So patient-centered communication leads to, please select all that apply in this case. And we'll keep it for a longer time, given the options. Any thoughts on the results, Adiomi?
No, I think you guys are pretty accurate. I mean, communication takes all parties. Everybody must be involved. And that's for patient to provider level. Any caregivers or extended family also can be involved. I think you guys are spot on and are on a great start.
All right, excellent. Adiomi, do you want to do the cultural humility one now or later?
We can just continue through the slides as regular, yeah.
Okay, so go to the next slide.
Yep. Okay, so my sister helped me poll some support groups, sickle cell support groups, regarding their thoughts on transition, communication, and advocacy. And I culminated some of the most important ideas and thoughts into a few of these different slides, where we did receive overwhelming feedback regarding the care and perspectives. So I just want to share a few of what the patients have said. Anonymous says, "We come to you for guidance. Help us navigate to better health rather than frustration. So your role is crucial to our overall health. You know, the more we know, the more we equip with, and the more we can better plan. So better experiences like this lead to better health. You know, because when our stress rises, you know, we tend to get more sick. And that's what we want to avoid." Next slide. Specifically talking about transition, Tanoka Sawyer shares that the process can be made smoother by letting us meet with our new doctor to see if they are a good fit for us before we leave the children's system. I know for me, it was basically like, you're 18 now, go see this person. They should prepare us for the fact that we're going to have to make decisions, not our parents. Now, this is important because transition is always sort of a scary time for sickle cell patients. You know, everybody knows there's an affinity for children, and we give them such special and precious care. And when we do have to transition to an adult program, that care and that sort of attention doesn't always transfer over. So as a topic of transition, I think it's important to always remember, you know, get the adult facilities involved as soon as possible. There is a great push to do more research in regards to what transition programs exist today and how we can adopt those best practices into transition overall for sickle cell disease patients. I know while working on the FLCOI project, that was a good and highly thought of after topic to research on ways to improve that. And of course, key points here, start transition early so that we get to know more about the adult team and feel comfortable, you know, rather than just pushing us off at 18 or 22 saying, go see this person. You know, what if we meet them earlier? What if they come to our clinical visits at 16, and we start that transition as an early, process and get comfortable with both teams so that we have a more involved and less siloed approach. Of course, doctors need to talk to each other as well. Healthcare professionals need to talk in general. We all may have different issues going on. For instance, my sister has a kidney doctor, and then she also has a hematology doctor, and then whatever other doctor she has to go to. You know, if we can bridge the gap, you know, and sometimes it's a lot on patients to be that one source of information to communicate out to the different doctors, but let's think about ways we can bridge that gap and make it all a better communication and experience for all parties involved. Next slide. So Shayna Walker says, ask us, besides pain medicines, what else can they do to ease our pain? You know, there's compassion that's needed when we're dealing with somebody who has a chronic disease. She says, have a heart, basically, and don't judge us. So we're always searching, I say we as a sickle cell population or somebody who is affected by chronic disease, we're searching for a type of normalcy. And when you don't get that, you kind of feel outcasted, and that's not the goal we're going for. We do want to always feel as though we can go to our healthcare professionals in full confidence and in full honor and communicate our issues and what we're thinking without feeling outcasted or judged. Next slide. A big topic here. We are not all drug seekers. And I think this is very important. I want to share a personal experience that my sister had a few years ago. A doctor said to her while in the ER, in Africa, people with sickle cell disease can handle pain and don't need that much pain medicine. Very odd thing to say when you're in the ER. And I don't think this is something you want to hear when you're in a lot of pain, because you don't know how to react to that. I'm in pain. All I know is right now I'm in pain, and I'm looking to you for help to solve my issue. And as future professionals, I encourage you to understand that there needs to be continuous sensitivity training, empathy given, cultural education, and workshops for this cultural sensitivity. So, Kunal, I think it's a good place to have the next poll question.
Sure. So the question is, implementation strategies to improving cultural sensitivity include? Please select all that apply.
Perfect. So yes, improve knowledge of the community. I think it's very important to always collaborate with, some of the advocacy leaders and community leaders, and then conduct outreach to underserved populations. Very important. And a lot of sickle cell patients do come from underserved populations and don't have the same resources that a more affluent neighborhood would. So it's very important to remember those different finite details when you are dealing with a chronic disease. Okay, next slide. So if it were you, how would you want to be treated? This is all about compassion, when you're taking care of somebody, think about, put yourself in their shoes. Next slide. Treat us as like we're a close family member. And I think that also goes into compassion, patience, and empathy. If the person laying in that hospital bed who's sick is within your family, how would you react? How would you treat them? Think about it like that. Next slide. Okay, so real results. Both Edie and I have made major strides in our continued health. I'm happy to say we're both over the age of 30 and doing well despite the setbacks that we've had. You can go to the next slide now. So currently Edie, who's on the left, is getting her master's degree in psychology and works part-time. This is very exciting for us because at one point, Edie has had many near-death experiences, too many to count, and it's very important, I think, to mention that. Although very emotional for me and my family, we are survivors. We're very strong people, and I want you guys to feel empowered to understand that. Me, personally, I'm a marketing consultant. I work for American Express. I'm also a seasoned model and photographer. So despite what our blood looks like or what our diagnosis is, we strive to continue to reach our dreams and our goals. Next slide, Kunal. All right, to sort of wrap this up, I wanted to finish with a few different quotes. So sometimes joy is the source of your smile. but sometimes your smile can be the source of your joy. As mentioned, despite our rough journeys, we have both been endeavored to live a life not dedicated to sickle cell as a defeated individual, but somebody who is dedicated to raising awareness, education, and most importantly, we've learned to smile through it and live our lives to the fullest despite the diagnosis. As future healthcare professionals, you have a chance to truly inspire and uplift your patients, like Dr. Frank Pong did for our family. It won't always be easy, and I'm pretty sure you didn't get into the stool because you wanted it to be easy. You know, smiling is probably the easiest thing that you can do in your role, so always promise me that you'll start there. Next slide. And finally, another quote from my mother. She's a healthcare professional as well. As I mentioned, she's a nurse anesthetist. And she just wanted you all to know that you all need to be sure to take care of yourselves and your emotions so that you are able to give better care to those who need it most. We need you as healthcare professionals. From that empathy and care, providers to not allow their emotions to be strained or overwhelmed by the situation of their patients. If you are, you won't be receptive to proper care and delivery. So be sure to take care of your emotions, and you'll be able to give better care. And I think that's it. Thank you guys so much for listening. I hope this was helpful, succinct, and you found, education and empowerment from it. So if you guys have any questions, I don't know if Kunal, if you want to take those now or wait till the end.
Yeah, we can take one right now. And one of the questions is, do you think it helped that your mother was a nurse so that the medical providers would respect her input more than average families?
I think sometimes it's a double-edged sword. That's a great question. I know at times we have felt as her daughters felt empowered because, yes, my mother is a nurse and she knows how to care for us the best. However, at times, doctors go through schooling too, and they have earned their right to be labeled doctors or healthcare professionals. So they may find that to be a little bit intimidating, or she don't overstep her ground, or stay in your place type of thing. We've had those experiences, but from an overall standpoint, from my subjective standpoint, I think it is very helpful that my mother is a healthcare professional who also understands that, the patience and empathy that's needed.
Okay. I think there was a question or a comment, but it stopped halfway. So if the participant wants to type in their question, we can take one more. All right. How about we continue with the question answers in the end? Is that okay, Adiomi? I think the question was left incomplete, so we'll wait till the end for the participant to complete the question.
Not a problem.
Okay. Well, thanks very much, Adiomi, for sharing your experiences and thoughts. It was really helpful. And on that note, it is my pleasure to invite Jana Monaco, who is an advocate for isovaleric acidemia. She is a mother of 4 children, and 2 of her children have isovaleric acidemia. Her son Stephen now has severe neurological impairments and complex health issues due to late diagnosis, and her daughter Caroline was tested in the newborn period and provided treatment to prevent complications. We are very pleased to have Jana help us with our NIMEC education activities, and Jana has participated in panel discussions with various national and regional organizations, including the March of Dimes Congressional Briefing on Medicaid and Children and the 50th anniversary of newborn screening on Capitol Hill. She's given many media interviews on newborn screening, to the Wall Street Journal, Newsweek Magazine, Northern Virginia Magazine, the Potomac News, CBS, NBC, and ABC. So it's indeed a pleasure to have Jenna with us. So Jenna, please lead us and guide us through today's discussion.
Thank you, Kunal. It's so almost daunting to hear everything that I've been involved with, and I'm wondering where the time goes and how I have time. As you mentioned, I have the 4 children, but it is my 2 younger ones that brought me into the world of rare diseases. And Kunal, you can switch to the next slide. And this is my son, Stephen. He is the 3rd of 4 children. And my journey with Stephen has really epitomized for me what care coordination means, what for me, what it looks like, what it needs to be, and so forth. It's something that I would have never really given a second thought to. But a little background about Stephen. He is now 19, and these pictures are of Stephen prior to his metabolic crisis, which occurred at age 3.5. He was a very typical normal child, as you can see, developing normally until age 3.5. And that is when he went into a metabolic acidosis, which I believe is the next slide. He just didn't wake up one day. He was fine one day. The 24 hours later, after I put him back to bed, thinking he had a stomach bug, I found him unresponsive the next day. He was a 911 call, taken to our local hospital, transferred to another one, and they were a little stumped as to what was the problem. And 24 hours later, their suspicions were confirmed that he had the inborn error of metabolism called isovaleric acidemia. Isovaleric acidemia is an organic acidemia, and it is detectable at birth with newborn screening. Unfortunately, when Stephen was born, isovaleric acidemia, or as we refer to as IVA, was not on the screening panel in Virginia and many other states, most other states actually. Therefore, that is why he was missed. There were a few opportunities where it could have prevented itself, but it was missed along the way due to just the lack of knowledge and awareness with the medical profession. So the pictures that you see here are 24, one of them is, he was in this condition 24 hours after the previous slide where he is holding a little hand mixer. He was in a coma on life support and not expected to survive. In this process, he had a traumatic brain injury as a result of the acidosis. We almost lost Stephen, but fortunately he survived, and it did leave him with complex medical issues and severe developmental and physical disabilities. So it's been quite a long journey. Next slide. With Stephen. This is my daughter Caroline, who was our little surprise a year later after Stephen's crisis. She also has isovaleric acidemia, but we decided to do an amnio, which we knew we could screen for IVA at the time, and that was confirmed. So it's 25% chance with each pregnancy since it's an autosomal recessive gene. And the amnio did confirm that Caroline was affected with IVA, which is an inability to break down the amino acid leucine. But the knowledge ahead of time allowed the team at Children's National in Washington, D.C., where Stephen was being managed and still is, to really plan for Caroline's arrival. So she was induced a week early. She was at Children's National within 2 hours of delivery, and with a very detailed protocol letter was acted upon right from delivery on. And this just enabled to prevent her from becoming catabolic and suffering the same kind of fate that Stephen did. So she today is a normal, healthy 14-year-old, managed with the genetics team at Children's National along with Stephen. And unlike Stephen, she does not see the many specialties that he has to on a regular basis. Next slide. And that's where we look into care coordination. And when I looked at each child, I looked at that, and I said, for Stephen, these are all the specialties, and this is all a part of Stephen's life that has to be coordinated on a daily basis. As I mentioned, because of Stephen's complex medical issues and disabilities, he is seen by many specialty clinics within the medical field. He also has the insurance side of life, education, and I put the courts here because Stephen turned 18 last year, and so we had to seek guardianship for Stephen and also go down the path of SSI since he qualified. So it's a lot of work to coordinate all of these areas of his life. And a lot of times when you have a child with a genetic condition, you have many hands involved. And if that care coordination is not done in a very team-oriented process, it can leave a family floundering. At the heart of it all is really truly the parent, who has to manage and coordinate all of this and ensure that everyone is communicating with one another, and that information from one entity to another is communicated and shared, because they all are a significant part of a person like Stephen's life in regards to just his overall being. Next slide. This is what Caroline's looks like. Very different. She too has, as I said, is seen in genetics. She is sometimes, well, she's also seen in orthopedics for a little minor spinal curve. She has her inpatient stays, which are so few compared to Stephen's. He has had many inpatient stays along the 15 and a half years. Specifically, he has had 6 surgeries in the past 6 years, some of them very complex. It'll be 6 years since he had a major spinal surgery. Caroline just sees to have her orthopedics to have her spine monitored and the curvature, which is very minor. She also has the insurance issues, but it's a lot simpler compared to Stephen. And of course, education. And for the most part, everything is pretty normal for Caroline, and genetics truly is the primary focus for her. So a lot less coordinating. However, that care coordination for her is just as important, and it is important to ensure, again, that there is that team concept when coordinating all the areas of her life. Next slide, please. When we talk about care coordination in the world of genetics, especially with somebody with a genetic disease, it's very different, and there's a lot of commonalities, but it's very individualized because, as we all know, every rare disease is different. Some we can identify, some needs we can't even put our finger on it yet. But when you look at my 2 children, it is definitely in an individualized process. There are diverse levels of care coordination because you have, whether it's on a daily process of outpatient services, which looks very different from an inpatient process. Care coordination has to be very patient and family-centered because it really is the patient is at the heart of everything that is being done. It is that person's well-being that is truly the ultimate benefactor here. I can't even stress how much effective communication is needed to manage someone with a genetic condition like this and who is complex like Stephen. And this is where electronic medical records are now such a big part of life. And I think maybe, Kunal, this is a good polling question time, as we touch on electronic medical records, or do you want it?
Sure, we can do it now.
Okay.
Okay, here you go. So EMR could be used as an effective communication tool. A few more seconds.
Okay.
All right.
Awesome.
So,
I was hoping that was the response.
yes, and we got it.
Okay. We can go back to that slide.
Okay.
I'm so glad to see that response to that question. Electronic medical records didn't exist when Stephen had his medical crisis. And it was very difficult for us because there was a lot of information that had to be handed off on a regular basis. And Stephen's primary physician, his pediatrician, was not a part, it still is not a part of the Children's National System. And we live in Northern Virginia, and his team is at Children's National in Washington, D.C. So our primary care physician was always lost with when anything was happening with Stephen, any outpatient visit, any inpatient visit, until either I made a phone call and communicated what was going on, or passed on the latest results from a latest specialty clinic, or that the letter from the specialty clinic arrived to our primary care physician. So I had to be that parent always asking, did you get the notes from the geneticist? Did you get the notes from the neurologist, and so forth? And it's a lot of paperwork, but sometimes it was very time consuming, and it took time for all of that information to transpire to that primary care physician. So there was really a break in the system there. Once Children's National went with electronic medical records, it really even improved the communication and the care coordination within its own system, because it was easy for a physician to sit there and pull up notes from, another team member within the hospital or within an outpatient clinic. It still wasn't very easy for our primary care physician. Since then, the whole EMR system has drastically improved, even with Children's National, like it probably has with most hospitals. But also, an IT system, and I forget the name of it because I am definitely not an IT person, was available to our primary care physician, which he was able to buy into, and that gave him access to Stephen's and Caroline's records at Children's National. So that has really taken a lot of the pressure off of me, that I don't have to worry about whether something is being missed, and that I can speak to that primary care physician or any of the physicians and refer to something else from another area of Stephen or Caroline. And for example, Stephen just had to see cardiology, which is a specialty that he has not had to see because there was a concern about something on an EKG. It was really nice to go and sit and see this new physician who really knew nothing about Stephen except for a brief looking at his history that he had just recently been inpatient. But I had to give him the little background on Stephen of what was going on and how he incurred his disabilities. And we talked about whether there was past EKGs or any other resources. He was able to sit there and pull up the EKG that was done on Stephen 6 years ago when he was preparing for surgery, and it was just to be cleared by cardiology that Stephen was okay for surgery. So he was able to compare that EKG, and if you can imagine trying to find a test result like that without an electronic medical record, it would be virtually impossible, because it would have been something that had to have been done well in advance. And so he was able to pull that one up and compare it to the one that was done on this past Wednesday, which was wonderful. And I didn't have to go hunting for something like that. I sat there and I thought about how wonderful this EMR is, making that communication opportunity so easy. And it was really a good example of care coordination right there. So it just shows you, even within one entity, how those EMRs are important. And I think their value is going to be even greater as time goes on, when people can really truly see how they are useful within various practices, and especially when we are looking at children who are going to transition into adult care. I think it's invaluable to be able to allow the next generation of physicians that are going to be a part of these children's care to go into. So I can't stress enough how much those EMRs are to this. Next slide. I just wanted to, yes. If you could go back to that one, Kunal, for a minute. As far as care coordination with lifelong relationships, yes, Stephen has been seeing the same physicians since, give or take a few, that have left since he was 4 years old, basically. And they know him so well, and even to the point of his wheelchair, it's rehab engineering. I drive to Charlottesville for 2 hours so that he can still see the same team, because it's far better than starting with somebody fresh. So yes, you do establish these lifelong relationships, and especially with genetic conditions, because we are a very small world. So overall, the improvement on health and quality of life is definitely there when you have an appropriate and effective care coordination team happening. Next slide. The reality of care coordination, as I mentioned earlier, it works at different levels. At different levels, it looks differently. Sometimes inpatient stays, it's much more streamlined than it is on the outside. As I mentioned, the troubles it was before the EMRs, that has definitely improved. However, you have to have people willing to sit there and even to utilize those EMRs most efficiently. And I understand some IT systems aren't necessarily the best that they can be, so there are IT glitches that can actually get in the way at times. Care coordination can be a theory to some, and others are embracing it. There, I think, unfortunately, in medicine, especially maybe with genetic diseases, for those who are not as well versed in genetic conditions, that not everyone embraces it. I think there can still be that I'm in charge, I'm the expert at this, or that part of that patient that doesn't apply to me, and they don't quite understand how coordinating with everyone is so vastly important for the overall well-being of the patient, that it can't be siloed. With somebody like Stephen, even though every specialty, they take precedence at any given time based on what could possibly be going on, I often tell people at the root of everything is my children's genetic condition, because no matter what's going on, and Stephen with all his admissions, inpatient, whatever might bring him to the hospital, the foundation that has to be remembered is that genetic condition, his IVA. And whether the urologist or neurologist or the GI physician knows anything about it, even if they don't, they have to learn. And I always stress that when we do patient family rounding with the residents and medical students, I always stress, as the parent advocate that I have to be for my son, to say, you're going to make this decision for his treatment right now, but remember his metabolic condition and how does that impact that. And that's where I say the parent is still the care coordinator in many instances, and that is so true, because sometimes things are missed along the way, but it is ultimately still that parent ensuring that everyone is making that effective communication. And we are usually the ones that can pick up when we can tell when somebody hasn't communicated some sort of information in the care. we talk about the medical home, and that is especially true for the medical home, because I often say, yes, I am that person at the center of the medical home, and it would be nice to have that perfect definition of the medical home apply here at times, but it's getting better, and I do believe the EMRs are a significant jump with that. Next slide. When we look back at the impact of the EMRs, we've mentioned just how it has improved a lot for everyone. It is just such a great way to share information. It's at your fingertips that everybody likes to have in our very technical world. It gives immediate access to those notes and tests and lab results, like I mentioned, just with our recent experience. Sometimes, and I think, you know, the better the IT system that's being used, the better the access is, and it has to definitely be user friendly. And it's available to all the providers and specialists. When we were able to have our primary care physician communicate with, you know, and see all our records, it just really changed life. Could you go back to that slide, Chanel, please? Thank you. The management overall is really impacted by everything with the EMRs, and I think they force communication. They facilitate, but it really influences and gets people communicating, because they have it there. They know who to speak to. They see who put in whatever notes, who did whatever test, and they know who the go-to person is if they have a question. And when you're transitioning of care from unit to unit within a hospital, or you're going from inpatient to outpatient, it really makes a big difference. And I think it helped in the reduction of medical errors as well, because the information is there. And as I mentioned again, it does take some of the burden away from the parent to be able to have that source of communication right there. And it improves our ability to communicate with all the providers when we are going from one specialty to the next. We can ask, we can refer to a certain situation, a certain test, a certain appointment, and we can ask to have certain things pulled up. Or even if we have questions, it makes it easy for the provider to go back and find that information. Okay, next one. As I say with this, you can wish for it or you can work for it, and it's your choice. And if we all have this perspective that we, you know, what we might define as care coordination and what we want that to look like, and especially when we are thinking genetics, as the genetic disease world is growing and everyone is becoming more aware of genetics and how, you know, genetics are just becoming such a big part of medicine in so many instances, we have to choose to work to make that care coordination the best that we want it. We have to choose to make it very patient and family-centered and effective and over the lifespan, because when I think back to my children, their condition, which brought me down into the world of advocacy for newborn screening, is it's beyond newborn screening. It's beyond that diagnosed baby. These children, thanks to medicine and the education, the knowledge and awareness, are growing up. They are becoming adults, and we have to ensure that this process is improved and mastered from the time they're born, because it's going to carry with them throughout their lifespan, and it's going to make it that much easier in every step of the way. So with that, I am now open for any questions, and I thank you, and I can honestly tell you that it has definitely made a difference in my children.
Jada, we have one more poll question. Shall we launch it now?
Sure.
So it's about the advocacy. Advocacy for a child with genetic condition is an ongoing phenomenon. So after today's presentation, I think it should be obvious, but we'll see. All right. Yep.
Yes, that's what I was hoping, and as I mentioned, it definitely is an ongoing phenomenon because, as I said, children are growing up. Their care is going to change. Their needs are going to change. Some of it we don't even know what that looks like, and we have to advocate in all aspects of a child's life as they mature to educate that next person that becomes involved in their care, and to understand that their needs, and to really jump on board wholeheartedly.
Excellent. Thanks, Jenna, for a wonderful presentation. There is a comment from one of our participants regarding the electronic medical or health records. The comment is, it's also important to make sure everything is accurate, including in the EMR, and families can ask for amending, correcting if needed. Would you like to add anything to that, Jenna?
Oh, I couldn't agree more. And I think the EMRs, I think, demand accuracy, and I think they're probably easier to understand now because, it used to be people trying to read providers' notes, and maybe they didn't always get transcribed very correctly, and that's where you stand to have some errors. But when somebody's putting something into an EMR, I think it's definitely important, and I think it helps make it a little easier. But I think it's really great for families to inquire about it at times and ensure that the information is definitely accurate. One of the things that we are doing now that I've noticed since Children's has really improved the EMR system, as they have went through phases. First it was inpatient, then it was certain parts of outpatient clinics, and then it was in phases, and then the last phase was all the remaining outpatient clinics. And when we pull up medications, and it was really great because, when you go through any visit, you are asked, what medications are your child on? And I think, it's a very long list. Well, it's very nice for them to pull up the medication list on the EMR, but what we do have to do is do a checklist because we have to make sure it's accurate and updated. And often, if the last time anything was inputted into the EMR was an inpatient, well, some of those medications don't even apply now, and it's very important, I think, for the family member to ensure that that piece is always updated, to even start.
Thanks, Jenna. A follow-up question on EMR is, not a follow-up, but additional question on EMR is, do you feel there is any information not currently disclosed in the patient accessible EMR that should be included?
Not that I'm aware of. I believe what's going on in the EMRs is, what they've done right now is taken everything that was in their paper records and put it into the EMR. I'm not really sure for others if there's something that is omitted or not. Like one thing I don't know, if it were a new patient, are the newborn screening results in there? That I don't know. So I really can't answer to that. Everything that is from my children's records has been transcribed into an EMR, and there isn't anything that has been omitted yet. One thing that I have stressed that they have to make sure that is available to them are the guardianship notes. And I think that is not always there.
Adiomi, any thoughts on the electronic medical records given your experiences?
Yeah, so to piggyback off of what Jana was saying, I think it is important to make sure they're as accurate as possible. One experience that I did have was, I got sick out away from my primary care doctors, and while I was in Las Vegas and my doctors are here on the East Coast, I got sick and they were able to pull up my records and talk directly to my primary care team. And that was extremely helpful because, one, I'm in a foreign land, and two, they know what care immediately to give me just based on those records. So it's a huge testament to the technology and the type of care that you can give just based on those EMRs.
Thank you, Jenna and Ediomi. Quick reminder to all our participants, should you have any more questions or comments, please feel free to include them in the follow-up evaluation survey as soon as you access this webinar. And you are also welcome to email us through the registration email that you received should you have any more questions or need to continue the dialogue with our speakers or with NIMAC. On that note, thank you all for participating and completing the survey, giving us your feedback. And thank you to our speakers for sharing their experiences and helping us understand more about this topic. Thank you all and have a wonderful day.
Thank you, Kunal. It's been a pleasure.
Yes, thank you, guys.
Thanks, Jenna. Thanks, Ediomi.
Bye-bye.
Bye.